Hello and welcome to Longevity Physiotherapy channel. I'm Jordan and I'll be talking about a case of knee pain today. I'll have some exercises attached to the end to help if this case sounds similar to your own problems. So a bit of background, the lady that I'm speaking about is completely fit and well, no other medical problems. She's of middle-aged. She'd previously ran multiple half marathons and a marathon, but has taken a few years off running more frequently. And she's decided to restart, aiming to do a half marathon in a couple of months' time. When she started running, she noticed that her quads were feeling weak and was extremely proactive and hired a PT personal trainer to work on this with her in conjunction with her running. However, she started getting some knee pain on both sides, but her right was worse than her left. The pain was located right around her kneecaps, all on the front of the knee. She explained that she had also had some right lateral hip pain, so pain on the side of that hip on the bony point, when lying on the right side overnight and walking up hills for the last few months. The knee pain was starting to worsen, affecting her on longer runs over the weeks of doing the plan and the PT. Additionally, her knee pain was much worse for 2 days after a PT session when she was being active. When discussing her current exercise regime, she was managing 3 runs a week, 2 shorter runs and 1 longer run on the weekend, with 2 personal training sessions during the week targeting her leg muscles. Her pain was only during activity and she had no pain at rest around her knees, only some creaking when standing up after being sat for a while or going upstairs. On examination, she could walk normally with no limp. Looking at her hips first, she had full range of movement on both sides, but while pressing on the side of her right hip, so on the greater trochanter, which is that bony point, that reproduced her pain. Resisted abduction, which means taking the leg away from the body, and external rotation of the right hip reproduced her pain. Standing just on the right leg reproduced her pain, but she was able to keep her pelvis neutral rather than it tilting down to side. So it showed that she got decent control, but it was stressing that tendon a little bit too much. While looking at her knees, she had full movement of both knees with some crepitus or creaking when bending them fully, so you could just feel it getting a little bit tight. Her ligaments were intact, her meniscus was okay, and there was no obvious swellings or deformities around the knee. Her kneecaps were tended to move and to press underneath them. And then Clark's test, which is just a bit of compression over the top of the patella and a bit of a grind, that reproduced her pain too. She was weak on the knee extension, so the quad testing was weak, and then hamstring testing was okay. So on diagnosis, in terms of diagnosis, we found that she had right gluteal tendinopathy, which is a long-standing issue. And then patellofemoral pain syndrome, which is an umbrella term for pain behind the kneecap. Her likely cause of this was some early arthritis given her age, which has just been flared up by an overload picture of starting running again after having a few years off and adding in those two gym sessions a week. So in terms of management plan, we discussed continuing the PT but cutting the volume of exercises in half. We still want to be working the quads, but we just don't want to be pushing them too far because it's obviously overloading that joint behind the kneecap a little bit too much. We've also practiced and created some specific exercises for her for the gluteal tendinopathy and the knee pain. The exercises include a lot of glute work you may see compared to what you'd think to try and manage the knee pain, but that's because from our research that we've that other physios and doctors have completed, it's found that if we can strengthen the muscles up around the hip, we have greater sort of biomechanical control around the knee, which then decreases the knee pain, especially behind the patella. And then we also discussed her running cadence and her gait. So when discussing her cadence, we found that it was sitting at around 160, high 150s to 160. And we thought that if we can try and increase that, there's less time on the floor, so less force going through the hip joints in one hit. So if we're trying to increase that to over 170 to start with, and we're using a metronome for that. We also discussed, because she's a heel striker, and typically when we heel strike, we take more of that load through the knee rather than through the ankle. So if we can just drift onto that forefoot strike slightly, then that's going to force the ankle complex to sort of absorb a bit more stress. So really get the Achilles tendon working and get the energy transfer going through there. So key takeaways from this case is that there's no trauma that caused her pain to start. It just started gradually and worsened as she was completing more exercise. Key rehab is sort of pacing, so dropping down a little bit of that sort of PT work to maintain her running, as that's the main goal. She's wanting to get through this half marathon in a couple of months. But continuing with some of those PT quads exercises to slowly build her capacity over time to tolerate more load. The principles that she'll be following for the rehab are that pain up to 5 out of 10 is okay. All right, pain isn't any knee damage happening. It is just it's a warning against potential harm. So we're happy with some pain. We don't want that pain to last, so we want it to drop back down after the exercises are finished. So we're definitely within the sort of 2-hour period. We want that pain to be back down to normal. And that we don't want any increased pain overnight or any increased pain the next morning. Now, with tendon rehab in particular, we find that the tendons will warm up during exercise. So if she's out on a run and that hip starts to feel okay, but then it's afterwards. So that's when you want to really be watching those sort of 4 principles. And if that pain is worse overnight, then we have just pushed that hip a little bit too far. So thank you for watching. Hope you found that useful.